legislature about this issue. We know that opioids is a big issue right now in our country, and no one sees it first line more than an emergency room physician. I've been an emergency room physician in New Jersey for about 9 years now. I started my career in New York, where I was there for 4 years. And you definitely understand that addiction is a hard disease to treat. And in the emergency department, we're treating all patients that come in. And we have the job of trying to make sure that we are addressing patients' pain, their needs, but that we're also critically and timely finding out and diagnosing what's bringing them to the emergency room. Now, as the data that we've given with the written testimony, emergency department physicians only write about 4% of all opioid prescriptions. So it's a small percentage, but the percentage that we are writing for are for patients that are in acute pain and in acute situations. So if you're coming in because you have suffered a fracture from some sort of injury, fall, car accident, some sort of trauma, that is a case where an opioid prescription would be appropriate standard of care, and you wouldn't need to access the PMP for that. If you have a patient who's coming in with abdominal pain and you're working it up and trying to figure out what's going on, something that is very painful, not life-threatening, but significantly painful, kidney stones, gallstones, all of those things wouldn't necessitate going and looking up at a PMP, because the first thing that I'm going to do as an emergency physician is go and see my patient. I'm going to go in and find out what's wrong, why they're there. And it's my duty to treat the patient, find out what's going on with them, and do so in a timely manner. And also, as an emergency room physician, rule out a life-threatening emergency. So all of that is happening before I need to access the PMP. Where it actually comes in very valuable is that when you go through your differential, you're seeing a patient, and then something does not add up. So you're having a lot of abdominal pain. I'm ruling out all these life-threatening issues from appendicitis, gallstones, whatever it may be, a problem with the aorta. And now I'm doing all of this, we do our workup, we manage your pain acutely in the ER, and now we come to finding out a diagnosis and nothing is fit. Well, this is where it becomes very helpful, because I'm going to access that PMP to see if this is really a marker or a sign of a patient that may be drug seeking or may be coming in and may be failing some sort of medical issue because they're trying to get medication. And when I'm accessing it, I'm not accessing it because I think that I'm going to write the script for this patient. It's actually the opposite. I'm accessing it to see if they have a history that I can ascertain, because maybe they haven't been in my emergency department before. And now this is a time where we could have this conversation where I think you actually may have an addiction or a problem with opiates. I can see that you've gone to these different emergency departments, and this may be a sign where you may need some help. Now, we don't have it right now.